I'm going to start off with a case example. I'm going to review adolescent development, just clarifying type 1, type 2 diabetes, and talk about the endothelial and cardiovascular risk factor very briefly because you gave that beautiful overview before morning tea. And, of course, the party line of it's stressing the importance of dental health and type 1 diabetes interactions. So this is CK, 16-year-old Sudanese refugee, so from a very traumatic background, presented with newly diagnosed diabetes, routine diabetes education given, but poor attender at clinic. HbA1cs in this age group, we aim to be under 7.5, and these were really grossly elevated, really poor control. And we didn't see too much of him until the following year when he presented in mild DKA, but with severe toothache secondary to multiple tooth abscesses. So this boy, after his initial presentation, shouldn't come to hospital again unless he had a fracture or appendicitis, which was unavoidable. But this was totally preventable. And actually ended up being quite expensive because he needed an inpatient admission. His diabetes needed stabilising before he went off to theatre, pain relief, and he had multiple dental extractions, which I don't need to talk to you about how unfortunate that is. So I'm going to talk about adolescence and how do we define it? Is it age group, pubertal stage, behaviour, all of the above? I won't ask you to choose, but I think actually it's D. So I'd like to spend most of the time on the A's of adolescent care, and in my area, diabetes care. And actually the very first day of this was assumptions, and I actually got this from a paediatric dentist at one of the annual Elsden Story Memorial Lectures. And this is another tie that binds. My father-in-law was one of Rachel's mentors, and her dad was a wonderful mentor to me. And the other thing I wanted to just raise is that he was an academic activist, an activist for child dental health, by advocating fluoridation of Melbourne's water supply and just, you know, the family roast dinners. Prevention was talked about all the time. And so that's very much the theme of what we've been talking about today and that York set the scene for before morning tea. So the first one is assumptions, and don't assume that your adolescent knows anything, really. And make sure that you discuss it in a respectful way with the adolescent. Affirmation, it's hard to get it all right, but try to find something the adolescent is doing well and encourage accordingly, whether it's with their diabetes, their, I see you smiling with their, from the dietitian's point of view or dentist or whatever. Really thorough assessment, both medical and psychosocial evaluation. I work out at Sunshine now, you work in North Richmond, and some of the psychosocial settings are incredibly challenging, which I think for all of us in the room would find difficult. Acknowledgement of difficulties, working with them. Acceptance that the adolescent's best effort may be far from perfect, and you need to focus on building self-efficacy and harm minimisation rather than the perfect adolescent. None of us is perfect. Why would you expect them to be perfect? And I think preaching to the converted about advocacy and being prepared to go to bat for the adolescents under your care with parents, health, government, bureaucracies, and it was great to have a politician open the meeting this morning, schools and employers. Now, legal independence really has nothing to do with what a adolescent is actually able to cope with behaviourally and emotionally. And just because they're 18 doesn't mean A, they can get themselves to a dentist, B, they are able to pay for it or know how to pay for it, how they use their Medicare card, etc. So why are they different? They're neither dependent children nor independent adults. There's a lot happening in the frontal lobe in teenagers, and these affect their behaviour. You need to understand the psychosocial context of teenagers, recognising the tasks of adolescence, which I'll go through, and have a developmental stage appropriate management of type 1 diabetes, their nutrition, their oral health, etc. To have multidisciplinary healthcare approach. So teenage behaviour patterns are described as poor executive functioning, specifically characterised by poor impulse control. You'll often hear them just lose it and swear, and they'll get over it. You need to get over it and focus on their need at the time. Inability to understand long-term consequences of their actions, so there's no point in talking to them about what their life will be at 55, 60, you know, means nothing to them. Poor ability to plan complex tasks, and the characteristic of frontal lobe dysfunction is having a sound knowledge base about diabetes, what they should be eating, what they shouldn't be eating, brushing their teeth, etc., yet having difficulty applying this knowledge in practice. So in the adolescent years, they're developing mature relationships, accepting the physical self, emotional independence, physical and sexual maturation, economic independence, acquiring own set of values and ethics, and achieving independent social status. And this is a lot happening in their lives, and if they're not particularly interested in their diabetes, their oral health or whatever, on one level that's not surprising. Now, why is this so? I just want to very briefly talk to this. This figure actually was given to me by my husband when we were having domestic difficulties with a teenager. And it was actually published in 1949, so this is not a cultural thing. And what it is pooled EEG data, electroencephalogram data, from birth here to 20. Just look at the frontal lobe here, and the slow wave activity is very inefficient, and then you've got the fast wave activity. And you can see as the children grow older, they have this nice mature fast wave activity, and then at about 13 to 15, you revert to a pattern not dissimilar at 3 years of age. And just bear that in mind when you're seeing adolescents. They're doing their best, they can't help it. So, very briefly, type 1 diabetes is the second most common chronic disease of childhood, although I should say it's third because caries are the most common, after chronic asthma and caries. But affected individuals never grow out of type 1, and it currently remains incurable. And we're one of the highest worldwide for the prevalence of type 1. There's lots of people in Australia with type 1, and half of these are diagnosed before 18 years of age, and there's an increasing incidence. Now, this is the sort of mantra that those of us that work in multidisciplinary young adult diabetes clinics have worked with for over 20 years, and it's very, very good. We're checking that their weight's healthy, BMI's healthy, HbA1c, blood pressure. We're looking at their kidney function, lipid profiles, podiatry checks. Not all adolescent or young adult clinics will worry about feet. However, I don't know of one young adult diabetes clinic nationally that has a one-stop shop multidisciplinary care that includes a dental assessment, and I'm hoping that we'll be able to introduce that with advocacy of the group here today. Eye checks have been recognised for years, and you'll see some common themes coming out. Smoking is really terrible on its own, but in combination with type 1 diabetes is a major cardiovascular risk factor and major impact, detrimental impact on oral health. So microvascular complications and periodontal health can be reduced 27 to 76% with better metabolic control. However, only about a third of youth were able to achieve that. These are the cardiovascular targets that we're looking for, and as Jorg set the scene, cardiovascular health, periodontal health are very much interrelated. So they need to have just a little bit above HbA1c, a favourable lipid profile, normotensive, not obese, not smoking, physically active, and sedentary behaviour of less than 2 hours in a day, and a healthy diet. So these themes are coming up again and again and again. I'll just very quickly go through. There are predictors of lower self-care or metabolic control, and although this was done as far as diabetes is concerned, I suspect you would find very similar issues with oral health as well. So we need to find the right balance. You don't want to be too draconian or else they won't come to you. Teenagers just won't come if you're horrible to them. And so I'm sure none of you would be. But sometimes it takes a lot of patience. And it is challenging for families, carers, and above all for the young people themselves, who can often find this sort of medical interaction quite stressful. So you can't just let them do their own thing. Oh, well, if you don't want to brush your teeth, don't worry about it. Because they're going to have a terrible mouth. The same with their glycaemic control. It's obviously at their peril. However, if you just focus on, oh, you must brush your teeth, why aren't you brushing your teeth? Or why don't you remember to give all your insulin injections, then they won't come. And so you've got to pick your battles, do the best you can. And so diabetes management, have it in balance, have a slightly higher acceptable HbA1c, but you've got a happy adolescent coming along. Very briefly, type 1 autoimmune disease, insulin deficiency, much less common than type 2 diabetes, and this is secondary to genetic factors, obesity and sedentary behaviour, with those comorbidities that have already been discussed today. Type 1 and type 2 may coexist in 20% of patients with type 1 diabetes, and whether you've got type 1 or type 2, half of these patients will die with cardiovascular disease, and and both have issues with periodontal disease. So dental health in type 1, we need to emphasise prevention, regular brushing, flossing, healthy diet, which we've already talked about, fluoride supplements, and particularly rural areas, which may be on tank water and no access to fluoridated water, and ensure 5 to 6 monthly dental reviews. So the issue of endothelial damage, with Jorg's going through this, and so persistently high blood glucose, high blood pressure, high cholesterol, periodontal disease, smoking are all the contributors. Now, we're not looking at our young people's mouths, so we're not really too sure what state they're in. And when we were trying to advocate for podiatry, we were thought, when I was working at Monash, that podiatry was a bit of overkill in this age group. I just want to show you this here. So very few of them had numb feet that older people have, but quite a number of them had biomechanical abnormalities, which meant they were much more prone to callus formation. You get calluses, which then dry and crack, which then get infected, and then you get the diabetic foot scenario. So once again, we demonstrated that preventative measures in this age group was quite effective. So this is the sort of mouth that we're hoping that we, that we don't find in our young people, but I suspect we might. So that chronic inflammation, all this the inflammatory cytokines that are presented here or produced here circulate in the rest of the body and have a negative impact on the endothelium. So why is periodontal disease more common in diabetes? There's a lower salivary flow rate, and the importance of that was already mentioned. pH issues, higher glucose, and we usually don't see periodontal disease until puberty, when it starts as mild gingivitis and goes on from there. And the microangiopathy and also the high glucoses change the gingival flora, also the collagen, so tooth loss becomes more likely, and prevention of periodontitis is critical. So gum disease, abscesses, tooth decay, fungal infections such as oral thrush is what we tend to see. When studies have been conducted cross-sectionally, and there were no differences in caries between controls and cases, well matched for insurance status and dental visits. However, periodontal disease was much more common in those that had diabetes. Now, the relationship between dental caries development and glycaemic control with children and adolescents. This was a Scandinavian study, and the aim here was to determine behavioural and biological correlates of dental caries development, and essentially this showed the ones with the worst teeth when they presented with diabetes had worse glycaemic control after 3 years, and so that whole self-efficacy goes together. So we're establishing collaboration with the University of Melbourne and CoHealth to investigate oral health, starting with a pilot study at the Sunshine Young Adult Service. Dental hygienists and dentists, I think, are an essential part of this team alongside the rest. And I think we've said this. An HbA1c is a barometer of adolescent life. And usually means psychosocial issues. So I'll leave you with that conclusion.